we have looked at the brainstem, mainly the midbrain and the pons. Now we are going to look at the medulla oblongata. So the applied neuroanatomy and clinical reasons why we are studying it. Objectives: to review the external and internal anatomy, understand the respiratory and cardiovascular control located in the medulla oblongata, localize the lesions, recognize the various medullary vascular syndromes. As you can see here, the left side picture is a gross view of the lateral from the lateral side. You can see the pineal gland on the top, and below that is the aqueduct of Sylvius, which is the passage through the midbrain. And below that, this bulge is that bridge the pons. And this is the fourth ventricle, partly by the upper part of medulla and partly by the pons, the floor of the fourth ventricle. And third ventricle is above. This is the aqueduct there. And the cerebellum is behind the pons and medulla here. And finally, this is the canal which is continuing into the spinal canal as the spinal cord. And in the spinal cord also, you have the continuation of the space, cerebrospinal space. So when you look at on this side, you have got the pons, the blue color one there, and there is a basilar groove there in which the basilar artery sits. Below that is the medulla oblongata. A prominence are there. These two prominents are called the pyramids there. Lateral to the pyramids, the green color ones are called the olive projections. They are there. And then the pyramidal decussation is in the lower part of the medulla oblongata. Lower ventral part of the medulla oblongata, where the pyramidal tracts of the left side cross to the right, and the right side will cross to the left. They are coming from cerebral cortex, trying to reach the anterior horn cell in the spinal cord. And the crossation or decussation occurs in the lower ventral medulla. There is a sulcus called the posterolateral sulcus and ventrolateral sulcus and a median sulcus. Three sulci are there which the blood vessels traverse. And some nerves emerge through the spaces there, the nerves. Mainly we'll go and see the boundaries of this particular medulla, inferior part of the brainstem, between the pontomedullary sulcus and the foramen magnum. There is a sulcus called the pontomedullary sulcus. That is the frontomedullary sulcus. This is the frontomedullary sulcus. You can see here, that's the frontomedullary sulcus there. And that is the upper portion. This is the lower border of the pons. That is the upper border of the brainstem. Upper border of the medulla oblongata is the lower border of the pons. That is pontomedullary sulcus. And below will be the foramen magnum, through which it continues as the spinal cord. What is the length of this particular segment? This is around 3 centimeters in length, divided into two parts. One part is the caudal part or the lower part. The other part is called the rostral part. Rostrum means head. So between the two, the lower part is called the caudal part. The upper part is called the rostral part. The caudal part is closed because cerebrospinal fluid circulation is in the fourth ventricle. That fourth ventricle stops here and it becomes a canal there. So the lower part of the medulla oblongata, it is closed. Whereas the open part, the upper part is called the open part, and that is opening into the floor of the fourth ventricle is formed by the medulla oblongata. So what are the functions? It is a conduit of the ascending and descending tracts. Ascending tracts from below all the sensory tracts and spinocerebellar tracts, and the descending tracts are the motor tracts, and it houses several cranial nerves from 9 to 12. 9, 10, 11, 12, and also has got part of the fifth nerve and part of the seventh nerve also is there in the medulla. Okay, vital cardiorespiratory centers and visual centers. So what are the important structures there? The crossing corticospinal tracts ventrally and lower, Dorsally, the, the sensory tracts are there, and also you have the cranial nerves 9, 10, 11, 12, and also part of 5 and 8 also. 5 and not 7, 5 and 8, but because of the olivary body there. Vital, cardiorespiratory, and visceral centers are also. Look at the ventral surface or the anterior surface or the lobe or the surface below the base of the brain there. Anterior median fissure continues with the spinal cord. The pyramids are two paired longitudinal elevations containing the cerebrospinal tracts, corticospinal tracts, and pyramidal decussation at the caudal part of the medulla, or lower part of the medulla. Olives are two lateral ovoid swellings overlying the inferior olivary nuclei. You can see here the green ones are the olives there. They are sitting on the directly on the olivary nuclei. That's why they are called the olivary bodies. The projections there are the pyramids there. Okay. Now, anterolateral sulcus. Now, I told you earlier, there is an anterolateral sulcus on both sides. That is through which the 12th nerve comes out, the hypoglossal nerve. The posterior olivary sulcus is there. There the cranial nerves 9, 10, and 11 emerge. So near the posterior olivary sulcus, the 11, 10, and 12, 9, 10, and 11 come. At the anterior lateral sulcus will be the emergence of the hypoglossal nerve or the 12th nerve. Okay. Now, so what is the clinical importance? Upper motor neuron weakness by ipsilateral tongue, lower motor weakness in the ventral region. Supposing the ventral part of the medulla is affected, the corticospinal tracts are there. Definitely there will be ipsilateral tongue weakness. 12th nerve also is there. Ipsilateral tongue weakness, contralateral hemiparesis or hemiplegia. Upper motor neuron weakness plus ipsilateral tongue weakness and lower motor neuron signs will be there in the tongue. What are the lower motor neuron signs? There will be fasciculation, wasting, loss of power, deviation of the tongue to the this is the lesion is this side, tongue deviates. Why? Because of the unopposed action of the tongue muscles on the other side. Because of the unopposed action, the tongue deviation to the side of lesion. Okay? So ventral medulla involvement produces corticospinal involvement, and naturally they will cross after that the contralateral corticospinal tract signs, ipsilateral 12th nerve signs. 12th nerve is a lower motor neuron type of involvement, means there will be wasting, there will be fasciculations, there will be loss of power, so much so the tongue is pushed to the same side of the lesion because of the unopposed action of this one. In facial palsy, which side the face is being drawn, suppose there is facial palsy on this side, then because of the unopposed action. Here, the unopposed action pushes the tongue towards the side of lesion. Okay, now look at the cross section there. So you have the posterior median sulcus, you have the fasciculus gracilis, fasciculus acunatus, nucleus gracilis. Here it is fascicle, this nucleus gracilis, nucleus cunatus, fasciculus gracilis, fasciculus cunatus. What are these two? These are the ones which carry the posterior column sensations, right? Fasciculus gracilis medially and then fasciculus cunatus laterally, they carry the posterior column sensations. Then there is a central canal which continues above in the rostral part with the floor of the fourth ventricle. Okay, and these are the trigeminal nerve nucleus and the tract of the trigeminal. So this is the spinal nucleus of the trigeminal nerve descends via the medulla into the spinal cord. Then you have also got the medial longitudinal fasciculus. What is medial longitudinal fasciculus? Yeah, the one which connects the eyes, all the ones, medial longitudinal fasciculus. And you have got on the lateral side, you have the lateral spinothalamic tract, and also you have got the posterior spinocerebellar tract, anterior spinal. The red one is posterior spinocerebellar, green one anterior spinocerebellar, and the yellow one is the lateral spinous. So all these are laterally placed. And medially we have the pyramids, and the pyramidal decussation is occurs, and this is the median anterior median fissure, and hypoglossal nerve comes somewhere out from here. Okay. Now any ventral lesion, what will it involve? It involves the pyramid and the hypoglossal. Pyramid will produce symptoms on the opposite side. Hypoglossal will produce lower motor neuron on the same side. Okay. This is called ventral lower medullary involvement. Okay. Medial medullary syndromes. These are called the medial medullary syndromes. Whereas lateral medullary syndromes are, these are the lateral medullary syndromes. They are different. There are two syndromes, medial medullary syndrome and lateral medullary syndrome. We'll come to that. Dorsal or posterior surface of the this one. This is the dorsal part. The dorsal part is that one. This is the ventral part. Then what is happening in the dorsal part? Closed medulla, continuation of the gracile and cunate fasciculi, ending in the gracile and cunate nucleus, or gracile tubercle, cunate tubercle, over the nucleus, where the second order neurons are related. Open medulla forms caudal floor of the fourth ventricle. Okay, key features of the floor: hypoglossal trigone, the medial, and vagal trigone, which is lateral, area posterima, and vestibular area. Clinical: dorsal lesions will produce dorsal column defects, vestibular symptoms, and intractable vomiting and hiccups from the posterior involvement. So whenever you have dorsal column involvement, dorsal part of the medulla is involved, dorsal column defects will be there. What are the dorsal columns? The trigeminal is there. This will be ipsilateral. The spinocerebellar are involved. That is contralateral. If these are involved, the fasciculus gracilis and cunatus, you will have the fine touch and vibration sensation effects. Okay. And when the area posterima is affected, naturally you will have vestibular symptoms, and intractable hiccups and vomiting can also occur. Now, what are the other parts here? Yeah, the pyramid, you are seeing the pink color, anterior median sulcus, these tracts we identified. Then the hypoglossal nerve of nuclei we have seen there. Central canal is there. Nucleus gracilis, nucleus trigeminal nerve, this one. Yeah, all other things we have already identified. This is the decussation of the medial lemniscus. Medial lemniscus tries to cross to both sides so that it gets supply, gives supply to both the eyes. Now, longitudinal zone of the medulla. Neither ventral nor dorsal, but the longitudinal part of the medulla is involved, ventral, middle, and dorsal. The longitudinal involvement, you can classify them as ventral or basilar medulla, middle or tegmentum medulla, dorsal or the gracile and cunate nuclei part. So when the basilar part or the basal part of the ventral medulla is involved, pyramids, corticospinal, corticobulbar are the ventralmost. In the middle, you have cranial nerve nuclei 9 to 12, inferior olivary body, nucleus ambiguous, tractus solitarius, NTS, and reticular formation also is there. What is tractus solitarius? What does it do? NTS, nucleus tractus solitarius. It is there in the medulla, dorsal medulla, dorsolateral to the DMNV. That is the dorsomedial nucleus of the vagus. DMNV and the dorso and the NTS are side by side. NTS is slightly lateral, medial, compared to the DMNV. DMNV is dorsomedial nucleus of the vagus. The function of this is visceral sensory nucleus of the brainstem. NTS is the primary visceral sensations. For suppose that stomach is there, intestines are there, spleen is there, liver is there. They are visceral sensations. The visceral sensory nucleus is there in the NTS. It's called nucleus tractus solitarius, nucleus of the tractus solitarius and the tractus. and it receives inputs from 7, 9, 10, that is from the heart, lungs, GI tract, posterior one-third of the glossopharyngeal, posterior one-third taste, and carotid sinus baroreceptors and chemoreceptors. So these are all visceral sensations are felt in the nucleus tractus solitarius. Now, what is DMNV? DMNV is dorsal nucleus of the dorsomedial nucleus of the vagus nerve. That is very important for the parasympathetic preganglionic fibers targeting the heart, lungs, and GI tract. Arrhythmias, GI motility can occur when the vagus nerve, that is the DMNV, is affected. Okay, so there is another nucleus called nucleus ambiguous. So these three things you must know. One is called the nucleus ambiguous, which supplies the pharynx, larynx, palate, produces dysphagia, hoarseness, and absent gag. Dorsomedial nucleus of the vagus produces arrhythmias, GI motility disturbances because of the parasympathetic supply to the heart, lungs, and GI tract. And the nucleus tractus solitarius, that is the NTS, it is basically for the vagal tone supplying the taste, posterior one-third taste, and primary visual sensations are there in the NTS. Somebody might ask you these three things. That's why I'm telling. Longitudinal tract, so we are seeing here. Let us see now. Ventral basilar, we have seen. Middle is cranial nerve nuclei 9 to 12. Inferior olive, nucleus ambiguous. I told you nucleus ambiguous is basically for the pharyngeal sensations, the pharyngeal and laryngeal sensations. Tractus solitarius is the visual sensations. Reticular formation for the activity of the brain, and then arousal. Dorsal region, gracile and cunate nucleus, internal arcade fibers, medial lemniscus, floor of the fourth ventricle. These are the dorsal part. What is the teaching part here? Ventral is equal to motor tracts. Dorsal is equal to sensory autonomic cerebellar structures. Any ventral involvement, motor involvement. Dorsal involvement, sensory, autonomic, cerebellar involvement. Okay. Caudal. That is the closed part of the medulla or the caudal part of the medulla where the pyramidal decussation is there. Central canal is present at this level, crossing of the corticospinal fibers from the pyramidal decussation, and dorsal columns are there. Gracilis and cunate nuclei still present there. Spinothalamic tracts and spinal trigeminal nucleus and tracts are lateral. Spinothalamic tracts generally they occupy the lateral part. Lesions here predominantly motor weakness, often bilateral if large, with early sensory sparing. So very important. Why sensations are spared? Ventrally there are no sensory tracts. Only motor tracts are there, pyramidal tracts are there. Laterally the spinothalamics are there. Dorsally the cunate and fasciculus gracilis are there. So generally, if you have motor weakness, either one side or both sides with sensory sparing, you must consider lower medullary syndromes. Middle medullary. Middle medullary, there is sensory decussation. Internal arcade fibers from gracile and cunate nuclei cross the midline. That is the first time they are crossing. They have come all the way from their receptors up to this point. Then the crossing occurs in the cunate and gracile nuclei cross in the internal arcade fibers. Formation of the medial lemniscus in the ventromedial medulla. Pyramids remain ventral, and then spinothalamic tracts laterally, spinal trigeminal nucleus, and tract of the prominent dorsal spinal trigeminal nucleus and tract are prominent dorsolaterally. Lesions involve contralateral loss of vibration and proprioception with motor weakness. Why? Middle medulla, the crossing of the cunate and gracile nucleus fibers are there. They are called they are going to form the medial lemniscus. And if they are involved, you will have vibration and proprioception contralaterally and also motor involved. So if you have a contralateral vibration sensation and I have proprioception loss along with motor weakness. It is mostly a medullary syndrome. Now look at this diagram. So you can see the inferior cerebellar peduncle, the lateral most one, followed by the medial vestibular nucleus, then the posterior nucleus for the vagus nerve, and then you have the spinal nucleus of the trigeminal nerve, then you have the nucleus of the hypoglossal nerve, cunate nucleus, subhypoglossal nucleus, medial longitudinal fasciculus there, and then it's being pointed out. Spinal tract of the trigeminal nerve, reticular formation, nucleus ambiguous, spinocerebellar tract, posterior accessory olivary nucleus, raphe nuclei, lateral reticular nucleus, principal inferior olivary nucleus, medial lemniscus, medial ascending olivary nucleus, and spinothalamic tracts. And finally, on the right side, you can see the pyramidal tracts, where they are bundled, very nicely, and they would have crossed by now because it is in the lower part of the medulla, the rostral part of the medulla. So how did we look at medulla? We have classified it as ventral and dorsal first. Then we took the longitudinal ones. Then we took the lower medulla, middle medulla, upper medulla. Upper medulla is called the rostral medulla. Levels at the level of the olives. Central canal opens to form the caudal part of the fourth ventricle. Inferior olivary nucleus, deep to the olive, provides major input to the cerebellum. Olivospinal, cerebellospinal tracts go through the olivary nucleus. Nucleus ambiguous, bronchial motor and motor, this one for the brachial motor for the cranial nerves of 9, 10, 11. That is the swallowing and phonation, or the nucleus ambiguous. Tractus solitarius, visceral afferents, visceral sensations, taste sensation for the posterior one third of the tongue. And dorsal motor nucleus, or DMNV, a parasympathetic output to the thoracolumbar region and the abdominal viscera. Hypoglossal nucleus in the floor of the fourth ventricle, and vestibular and cochlear nuclei dorsolaterally, inferior cerebellar peduncle, medial lemniscus, spinothalamic tract, medial longitudinal fasciculus are also present. Classical level involved lateral medullary syndrome is called the Wallenberg syndrome. Okay, so we are talking about this one. Wallenberg syndrome is somewhat here. This is the ventral part of the major ascending and descending tracts. Descending tracts, what are the major descending tracts? Corticospinal tracts, the pyramids, corticobulbar fibers to the cranial nuclei, hypothalamospinal sympathetic fibers. These are the main descending fibers. Ascending tracts are dorsal column, medial lemniscus system, after sensory decussation, spinothalamic tracts carrying the pain and temperature, spinocerebellar tracts via the inferior cerebellar peduncle. So, clinical rule is ipsilateral cranial nerve deficit, contralateral long tract signs, localized lesion to the brainstem of the medulla. What is the teaching? If you have ipsilateral cranial involvement, contralateral corticospinal involvement, you are thinking of a brainstem lesion. Okay. Now, these are the blood supplies. You see, level of pyramidal decussation, level of this cunate fasciculus decussation, that is the medial lemniscus, level of the olives. This is the lower part, the middle part, and the more rostral part. Okay. What is the supply? You can see anterior spinal artery. Anterior spinal artery is blue. So this is the one. It supplies the anterior spinal artery. Vertebral artery. So this is lateral part. Posterior spinal artery. This is the posterior spinal artery. Posterior inferior cerebellar artery also is there. Posterior inferior cerebellar artery, posterior spinal artery, vertebral artery, anterior spinal artery. Anterior spinal artery produces this pyramidal involvement, vertebral artery, lateral, the spinothalamic tract, and posterior spinal artery, involvement of the fasciculus gracilis cunatus, and those things which are there in that part. Okay. vascular supply and clinical relevance. Vascular supply and clinical relevance. Anterior spinal artery supplies medial medulla, including the pyramids, medial lemniscus, and hypoglossal nerve. Then what will happen? If anterior spinal artery is occluded, you will get corticospinal tract signs on the opposite side and probably some vibration and proprioceptive signs also on the opposite side, and the glossopharyngeal nucleus involvement on the ipsilateral on the same side. Vertebral artery supplies the paramedian and some lateral territory. Posterior inferior cerebellar artery supplies the dorsolateral medulla, inferior cerebellum, and inferior cerebellar peduncle. Dorsolateral medulla is containing what? Spinothalamic tract, trigeminal nucleus, and also the fasciculus gracilis and cuneatus. Anterior spinal artery or vertebral artery, in fact, produce medial medullary syndrome. Posterior inferior cerebral artery produces lateral medullary syndrome. Definitely, you will have to learn these two things. Medial medullary syndrome, anterior spinal artery or vertebral artery infarct. Wallenberg syndrome, posterior inferior cerebellar artery or vertebral infarct. So, respiration is also controlled by the medulla. So, respiratory physiology we have to see. Dorsal respiratory group near the tractus solitarius, DRG, inspiratory neurons integrating peripheral chemo and mechanoreceptor inputs. Ventral respiratory group, VRG, in ventral ventrolateral medulla, active during forced inspiration and expiration. Dorsal respiratory group is for regular triggering of the respiration. If you want to take deep breath or if you want to exhale forcefully, you require the ventral respiratory group. And there is also called the Pro-Bollinger complex, pacemaker-like network generating the basic respiratory rhythm. Now, if that is disturbed, you have chain stroke breathing, you have irregular breathings and all that. Bilateral damage to the medullary respiratory center leads to the respiratory arrest. That's why any lesion, bilateral lesion of the medulla could be fatal. Cardiovascular and autonomic control. NTS receives baroreceptor and chemoreceptor afferents from the carotid, sinus, and the aortic arch. Rostral vertebrolateral medulla provides a tonic excitatory drive for sympathetic preganglionic fibers. Caudal ventrolateral medulla inhibitory neurons projecting to the above one, that is rostral ventrolateral medulla. Baroreflexes increase blood pressure, increased afferent firing at the NTS, activation of CBLM and the vagus nuclei, inhibition of the RVLM, and reduction in the sympathetic tone, decreases heart rate and blood pressure. So there is a baroreflex is there, but it's increasing, it will reduce and it controls. Lesions in these regions cause labile blood pressure and autonomic failure. So cardiovascular control is through the NTS, rostral ventrolateral medulla, and caudal ventrolateral medulla, and these are inhibitory and excitatory. The balance is the final output. Visceral and proactive reflexes, protective reflexes. Medullary reticular formation contains pattern generators for swallowing, coughing, sneezing, and vomiting. So nucleus ambiguus provides motor input for swallowing and phonation, and gag reflex, afferent limbus through the ninth nerve to the NTS, efferent through the 10th nerve. Area posterima is chemosensitive zone and then contributing to the vomiting and toxins and dorsolateral medullary lesions. Chemoreceptor trigger zone. Then you have medial medullary syndrome. We go to the two important syndromes. This is very important for you clinically. What is medial medullary syndrome? It is called Deserine syndrome, usually due to infarction of the ASA, anterior spinal artery, or penetrating branches of the vertebral artery. Understand these two things very clearly. Which artery is involved in medial medullary syndrome? Anterior spinal artery or the penetrating branches of the vertebral artery. Then, what are the structures involved in medial medullary syndrome? Medial medullary syndrome, medial structures, ventral structures are the pyramids, the corticospinal tracts, the medial lemniscus, which is the crossed part, and the hypoglossal nucleus, which is on the same side. So what are the things I get? Ipsilateral, pulmonary paralysis, contralateral, cerebrospinal tract signs, and contralateral. Also, we have the medial lemniscus, and that is the proprioception. Clinical triad, contralateral spastic paresis, contralateral loss of vibration and perception, ipsilateral lower motor neuron of the glossopharyngeal palsy, tongue deviating towards the side of lesion because of the unopposed action. Teaching phrase, tongue towards the lesion, limbs away. Okay? Always limbs are away from the body. So the limbs are away and tongue opposite side, tongue towards the side of lesion. Limb lesion is in the opposite side. Now you describe medial medullary syndrome, one of you. What is medial medullary syndrome?
Also called syndrome.
Which artery is involved?
Anterior-spinal artery
Or penetrating branches of the vertebral artery. Okay. What are the structures involved?
Spinal tract, medial lemniscus, and
hypoglossal nucleus. What will be the clinical picture?
Contralateral spastic metastasis, contralateral loss of vibration, proprioception, and ipsilateral loss of proprioception.
Correct. And then tongue towards the side of lesion. Why? Because of the unopposed action. And the tongue signs are lower motor neuron signs, whereas corticospinal signs are upper motor neuron signs. What are the lower motor neuron signs? Atrophy, fasciculations, or fibrillations of the tongue, and then you can have wasting of the tongue with deviation to the side of lesion, same side. Okay. Now, lateral medullary syndrome. Okay. What is the artery supplying? Posterior inferior cerebellar artery or vertebral artery. Medial medullary syndrome, anterior spinal artery. This is posterior inferior cerebellar artery, also called Warenberg syndrome. Vertebral artery is involved. What are the structures in the lateral part? Nucleus ambiguous is there, NTS is there, dorsal motor nucleus DMNV is there, vestibular nuclei are there, spinal trigeminal nucleus and tract are there, spinothalamic tract is there, inferior cerebellar peduncle is there, descending sympathetic fibers. Lateral part of the medulla is so very densely packed with all these things. What is nucleus ambiguous? What is nucleus ambiguous? The one which supplies the sensation to the motor nerve of the pharynx. Okay, through the glossopharyngeal nerve. So if you want to drink water, you require nucleus ambiguous. What is NTS? Visual sensory input. All the visual sensations. DMNV, this is the motor output of the viscera to heart, lung and gut. NTS is the visual input. DMNV is the visual output. Ambiguous, nucleus ambiguous is the laryngeal pharyngeal motor nerve. Okay. Vestibular nuclei for the balance. Spinal trigeminal nucleus for the face sensations. Spinothalamic tract for the opposite side pain temperature. Okay, already cross tract, spinothalamic. Inferior cerebellar peduncle again for the balance and then coordination. And sympathetic fibers for the autonomic control, like your control of the heart rate, respiration, blood pressure, all those things. So lateral medullary syndrome can produce what? Dysphagia and dysphonia. Why? Because of the ambiguous. You should know. You said there is dysphagia. Which is involved? Immediately ambiguous. Nucleus ambiguous is involved. Absent gag reflex. Why? The motor part is lost. Absent gag reflex. Because of that, there will be hiccups. There will be what you call, if you want to drink water, you will get what do you call in the not aspiration is one thing, and you will not be able to this, and it will come through the nose, the nasal regurgitation and all those. Then what will get? Ipsilateral facial pain. Why? Facial pain, temperature loss. Why? Because of the trigeminal nucleus and tract. You see the upper one, the upper line. Contralateral body and pain, temperature loss. Why? Spinothalamic tract. Inferior cerebellar peduncle, vertigo and nystagmus. Okay? And descending sympathetic fibers produces ipsilateral Horner's, ipsilateral limb ataxia. Now, this is a very bigger syndrome compared to that one. So, what are the Wallenberg features? You remember the nucleus. Ambiguous, dysphagia, dysphonia, NTS, gag reflex absent. Okay, dorsal motor nucleus of the vagus, that also produces it's a motor nerve for the viscera. In vestibular nuclei, there will be nystagmus and also ataxia. Spinal trigeminal nucleus, loss of pain and temperature on the ipsilateral side. Spinothalamic tract involvement, contralateral pain and temperature, inferior cerebellar peduncle, coordination and ataxia, descending sympathetic fibers, or nerve syndrome. You have to correlate with the structure and the function, right? Pyramids are usually spared. Why? Why pyramids are spared? Pyramids are ventral. Pyramids are ventral and medial. This is lateral. So pyramids are involved in what? Medial medullary syndrome. What is the involvement in medial medullary syndrome? Anterior spinal artery involvement, pyramidal tract in the opposite side, and then the vibration and joint sense on the opposite side, ipsilateral 12th nerve paralysis. That is medial medullary syndrome. Now you tell what is lateral medullary syndrome, madam? You are sitting idle. What is lateral medullary syndrome? Describe the structure and feature of lateral medullary syndrome. Which structure is involved, which is the effective side. Start. See the slide, no problem. You can see and tell. Nucleus ambiguous. What does it do? What is the function of nucleus ambiguous? It is the motor nerve to the pharynx and larynx. Okay. So naturally, dysphagia, dysphonia, absent gag. Okay. What is NTS? It is the visceral sensory input, afferent nerve. What is more DMNV? DMNV is the motor output. The sensory input, motor. Those are affected naturally. Okay. Then vestibular nuclei, nystagmus and vertebrae. So spinal trigeminal nucleus and tract. Ipsilateral. Ipsilateral phase, pain and temperature lost. Spinothalamic tract. Contralateral. Pain and temperature. Okay. Inferior cerebellar peduncle. Coordination and then ataxia. Descending sympathetic fibers. Horner syndrome, other sympathetic problem. What are spared? Pyramids. What about the posterior columns? They are also spared. Because posterior columns, the columns are very dorsal and the decussation is very, very ventral. This is happening lateral. So that's got nothing to do with the posterior column sensations. So what are the sensations spared? You must know. What are the tracts spared? Pyramids are not usually affected. Limb weakness is very minimal. Even if there is a weakness, it's very minimal weakness will be there. Whereas in medial medullary syndrome, dominant spastic paraplegia, spastic plegia will be there. Hemiplegia coupled with you have the posterior column sensations on the opposite side and hypoglossal nerve on the same side. Did you understand? This definitely you will be asked. You cannot escape knowing medial medullary syndrome and lateral medullary syndrome. You cannot escape from the examiner. Definitely you must. Okay. Now, lesions of the spinal specific nuclei. Which nucleus produces what? That also I am listing here for you. Okay. Nucleus ambiguous. It is a motor nerve of the pharynx and larynx. Dysphagia, nasal regurgitation, dysphonia. Uvula is deviated to what side? Uvula. Deviation away from the lesion. Okay. Just like facial paralysis. Nucleus tractus solitarius, NTS. This is the visceral afferent. It gives sensory input from the viscera, impaired baroreflexes, autonomic instability, loss of taste for posterior tongue, and epiglottis. Okay, so not only it is an afferent nerve, it is also the posterior part of the tongue taste sensation. What is the anterior part taste sensation? What is the anterior part? Facial nerve. Yeah, posterior part is by the glossopharyngeal nerve through this NTS. Okay, NTS has two functions: the posterior part of the tongue taste sensation and also the afferent nerve from the viscera. What is DM and V? It is the efferent nerve to the heart, lungs, and all the viscera. So much so, cardiac rhythm disturbances and gastrointestinal dysmotilities will occur because of the vagus nucleus involvement. Hypoglossal nuclei and nerve. This produces tongue involvement, ipsilateral lower motor neuron, tongue palsy, and dysarthria. Why dysarthria? Why dysarthria? Because of the tongue involvement. See, how are you speaking? Larynx is modulating, but the speech is finally produced by the tongue. Touch of the tongue to various part of the oral cavity produces different syllables. So if you want, you can try T, T, D, like that. You see where the tongue is moving. When you say T, the tongue is on the folded to the backmost part of the palate. T. Then you say D, it comes a little. When you say T, it comes even front. So the tongue movement only is producing the speech. Inferior olive involvement, delayed contralateral cerebellar signs, and possible palatal myoclonus can also. Okay. Inferior cerebellar peduncle, ipsilateral limbadex ataxia, and dyspmetria. Now, I'm going to give you a case. Elderly man, sudden right-sided hemiparesis, loss of vibration and joint and position sense on the right side only, tongue atrophy with deviation to the left side on protrusion. What is the case? What syndrome is that? It is written already, medial medullarism. Which artery is involved? Huh? Anterior spinal artery. Or vertebral basal, the basal branches of the vertebral artery. Medial medullary syndrome, sudden right-sided hemiparesis, right-sided loss of vibration and joint sense, left-sided lesion of the 12th nerve with tongue pushed to the left side on protrusion. The lesion is in the medial medulla. No cortical signs such as aphasia or visual field. Why that? Cortical signs are there, it could be cortical lesion, isn't it? We have to exclude cortical lesion. How? There is no aphasia, there is no vision. The moment patient's aphasia is not there, mostly are ruling out the cortical. Visual and aphasia, if they are absent, it is not cortical. Localization, left medial medulla involving the pyramids, medial lemniscus, and hypoglossal nerve also. Likely vessel, left anterior spinal artery. You must write not only anterior spinal artery, you must say left anterior spinal. You understand? No cortical signs, no aphasia, no visual field defect. Localization is left medulla involvement, pyramid, medial lemniscus observing the sensations of the posterior columns, and the hypoglossal nucleus on the same side. Likely vessel, left anterior spinal artery. Now, lateral medulla. A middle-aged woman with acute vertigo, vomiting, and unsteadiness. So, vertigo because of the vestibular involvement. Vomiting because of the visceral afferent and efferents are affected. Unsteadiness because of the cerebellar peduncles. Hoarseness of voice, choking on liquids, and impaired gag reflex. This is because of ambiguous. Loss of pain and temperature on the left side of the face because of the trigeminal nucleus and the tract. Okay? Right side of the body, loss of pain and temperature because of the spinothalamic tract. Limb ataxia and left hornness because of the cerebellar peduncle and the sympathetic outflow. Localization, left lateral medullary syndrome. due to posterior inferior cerebellar artery or vertebral artery infarction. Posterior inferior cerebellar artery of which side? Left-sided artery, because left medullary is in. Okay, so this you have now nicely understood. Now go to the bedside localization perils I am giving. If you have crossed finding, that is ipsilateral cranial nerve, contralateral long tract deficits, it indicates brainstem lesion. Crossed hemiplegia means cranial nerve involvement on one side, contralateral long tract signs are crossed hemiplegias. Tongue, lower motor neuron palsy, contralateral hemiparesis strongly suggests medial medullary syndrome, anterior spinal artery syndrome of the side of involvement. That is, if the left side artery is involved, left side you will have hypoglossal, right side you will have hemiparesis and then the posterior collapses. Dysphagia with crossed pain and temperature loss, ipsilateral ataxia, Horner syndrome indicate medullary lesions. Severe autonomic instability, intractable hiccups, vomiting fever, dorsolateral medullary involvement. Absence of cortical signs helps to distinguish brainstem stroke from hemiplegic stroke. Lateral medullary syndrome. Okay, acute dysphagia, hoarseness, ipsilateral facial pain and temperature loss, contralateral body temperature and pain loss, ipsilateral limb ataxia. What are the structures involved? First one, acute dysphagia, hoarseness because of what? Dysphagia and hoarseness are because of the ambiguous and vagus. Ipsilateral facial pain and temperature? Spinal tract and spinal nucleus. Contralateral body pain and temperature? Spinal thalamic tracts, because they have already crossed tracts. And ipsilateral limb ataxia? Inferior cerebellar. Most likely diagnosis? Lateral medullary syndrome, which artery is involved? Answer will be C. That is the answer. Answer is C. Posterior inferior cerebellar artery causing lateral medullary syndrome or Wallenberg syndrome. Now, I am giving you another case. Which structure is characteristically involved in medial but not in pure lateral medullary infarction? Characteristically involved. Pyramid. Medial medullary classically involved the pyramid. Why not spinal thalamic tract? Why not spinal thalamic tract? Why not nucleus? That's more upper and medial. More upper and medial. And then inferior cerebral peduncle is much lateral. Okay, pyramid is the one medial. The answer must be D. Okay. Now see the next question. What is he asking? Lateral medullary syndrome, ipsilateral facial pain loss and contralateral body loss due to involvement of what? A. What is third one? Huh? Sorry, sir. Third one. Third one I have to read. In medullary syndrome, deviation of the tongue occurs towards the side of the lesion. Why? Why? Because of the unopposed action of the towards. The answer is B, isn't it? Lower motor neuron hypoglossal lesion produces deviation towards the side of lesion. Next one you see. Why? Ipsilateral trigeminal spinal nucleus and tract. Contralateral spinal. Say, you understood that now? Now, go to the fifth question. Which feature favors lateral over medial medullary lesion? If you have this feature, you can say it is lateral. What is that feature? Ipsilateral lower motor neuron hypoglossal palsy is medial, isn't it? Contralateral spastic hemiparesis is also medial. Okay, contralateral loss of vibration perception is also medial. By exclusion, what is there? Ipsilateral limb ataxia is there. and that favors lateral medullary syndrome. The other three are medial medullary features, isn't it? That's why you have to answer like that. Ipsilateral limb ataxia, inferior cerebellar paralysis. Case 6, you see. I'm going to circulate these things to you so that you can keep them as a record. I generated some multiple choice questions related to this. You see, we have a big bank of question bank for the MRCP question bank. MRCP question bank is there. I'm MRCP. I pulled out some questions from that question bank related to the lateral and medial medullary syndrome. See that these are MRCP questions. A patient with medullary stroke means he had a medullary apoplexy, some sort of medullary stroke. Dysphagia is there, palatal weakness is there, vocal cord paralysis is there, preserved limb strength is there, dorsal column function is preserved. Most important, nucleus affected. Nucleus ambiguous. Hypoglossal nucleus doesn't produce it. Vestibular nucleus produces more about the balance and other things. Nucleus ambiguous, nucleus solitarius. Tractus solitarius one is more about the vagus. Okay. Here this looks like it is nucleus ambiguous because it is a pharyngeal involvement, dysphagia, palate, vocal cord. This is the motor nerve of the larynx and pharynx. That's when nucleus ambiguous. Now questions are over. Now I am giving you one more round of understanding. Differences between medial and lateral medullary syndromes. Okay. Etiology and vessels. Medial medullary syndrome, Deserine syndrome, infarction of the anterior spinal artery, medial branches of the basal branches of the vertebral artery. Lateral medullary syndrome, infarction of the posterior inferior cerebellar artery or vertebral artery. Artery है, you know now clearly. Medial medullary syndrome, anterior spinal artery, medial branch of vertebral artery. Lateral medullary syndrome, PICA, vertebral artery. Key features: medial, pyramids, corticospinal, medial lemniscus, opposite side, hypoglossal, same side. Lateral, nucleus ambiguous, palatal pharyngeal paralysis, NTS, visceral afferent, and then dorsomotor nucleus of vagus, efferent to the viscera, vestibular nuclei for the balance, spinal trigeminal nucleus and tract sensations on the face, spinal thalamic tract, opposite side pain and temperature, inferior cerebellar peduncle, motor coordination and ataxia, and descending sympathetic fibers, hardness. Then, motor defects. Motor and what will happen? Medial, contralateral spastic paresis with ipsilateral lower motor neuron of the hypoglossal may be added. The posterior column sensations may be there. Lateral, usually no major limb weakness. If you have limb weakness, it almost excludes lateral medullary syndrome, ipsilateral limb ataxia due to inferior cerebellar peduncle involvement. What are the sensory defects? Medial, contralateral loss of vibration, proprioception, fine touch, that is the medial lemniscus. Lateral, ipsilateral facial pain and temperature loss, spinal trigeminal nucleus, contralateral body pain and temperature because of the spinothalamic and dorsal modalities of sensations. Dorsal column sensations. What will be the cranial nerve signs? Medial, cranial nerve 12, involving the hypoglossal nerve, atrophy of the tongues, fasciculations, deviation towards the same side, dysarthria. Okay. Vinay, are you looking at some cranial nerve signs? 12th nerve environment, medial. Lateral, 9 and 10. Okay, 9 and 10. Involvement causing dysphagia, dysphonia, diminished gag reflex, palatal paralysis, uvula deviating away from the lesion, vestibular nuclei causing vertigo and nystagmus. Cerebellar and autonomic features. Medial, minimal cerebellar signs. Autonomic instability is not a feature. Lateral, ipsilateral limb ataxia, dysmetria, ipsilateral hardness, intractable hiccups, vomiting due to involvement of the NTS and area posterior. Clinical summary. Medial medulla, tongue towards the lesion with opposite limb weakness and dorsal column loss. Lateral medulla, bulbar symptoms with crossed pain and temperature loss. What is crossed pain and temperature loss? What is crossed pain and temperature? One side face, another side body. Crossed hemiplegia, crossed sensory loss. Crossed, this side is trigeminal involvement, opposite side spinocerebellar artery. Corticospinal, what is it? Spinothalamic tracts. Ipsilateral attacks in heart. Now, I have given a table also. You can use a tabular form. Medial medullary, vessel, anterior spinal, there posterior inferior or vertebral artery, key structures, pyramid, medial lemniscus, hypoglossal nucleus, there nucleus ambiguous, NTS, DMNV, vestibular nuclei, spinal trigeminal nucleus and tract, spinothalamic tract, inferior cerebellar peduncle, descending sympathy. It must be there always in your memory, these things. This table, motor finding. Contralateral, spastic paralysis, ipsilateral, truncal layman will have also the posterior column sensations, contralateral. Usually no major involvement, limb involvement or motor finding, ipsilateral limb ataxia may be there. Sensory finding. Contralateral loss of vibration and perception, pain and temperature are often preserved in medial medullary. Ipsilateral facial pain and temperature loss, contralateral body pain and temperature loss. This is called the crossed sensory loss, and dorsal columns are preserved. Cranial nerve involvement. Tongue deviates towards the side of lesion, dysarthria will be there, hypoglossal involvement, 12th nerve. Dysphagia, dysphonia, absent gag reflex, uvula opposite side, nystagmus and vertigo because of the cerebellar involvement. Cerebellar features. Usually minimal, medial medullary. Ipsilateral limb ataxia and dysmetria. What is dysmetria? I told you the other day. Not able to measure the distance. Finger. You want to catch this, it does not know where it is. Okay? Not able to measure that. Autonomic features. Mild autonomic involvement is usually not featured. Ipsilateral Horner syndrome, intractable hiccups and vomiting, that will be LAD. Clinical summary, tongue toward the lesion, limbs opposite side. Bulbar dysfunction, crossed sensory loss, ataxia. Such a wonderful, succinct talk on the medullary syndromes as well as on the anatomy, structures, what you have. This PDF is going to be with you. You use it. This midbrain, pons, this one, these three have come out very clearly, and you don't have to go into any textbook for these things. These are good enough.